I'm really pleased to be here, and I'm also very thankful that Alan and Linda spoke before me this morning as well, because it means I can speed my presentation up a little. So I'm talking about evaluation, and I get the most unsexy topic of everybody. But I think it's the most important topic as well, especially when we're talking about behaviour change, especially when we're talking about spending public money. There we go. I might have to do a Madonna, and you'd all run, trust me. So I'm just going to talk quickly about what is actually evaluation. Why do we do evaluation? Well, the reason that we do it is so that we know what's worked and what hasn't. It helps us to get sustained funding over time as well. It might help us to learn. There's lots of things. There's different types of evaluation as well. So we have longitudinal evaluation, which of course is the gold standard, but we don't always get the opportunity to do that. And as researchers in a university, we quite often get asked to do retrospective evaluations, which are not the ideal, but we can still learn a lot about a program and its delivery. And then thinking about the application of evaluation as well and timing. So all of my research always has been longitudinal research. I like big, long, clunky, messy data sets, really confusing data sets, just because I like to give myself challenges. So we need to be collecting data across time for longitudinal evaluations. So what I'm going to talk to you about today is designing a dynamic evaluation plan. What do I mean by a dynamic evaluation plan? So rather than a static evaluation plan where we're just taking a snapshot at one point in time, I'm talking about how you develop a plan that actually has flexibility and allows us to change with program delivery as well. As marketers, we don't ever just set and forget. We never put something out into market and just let it go. We are always monitoring what happens. So that's my perspective, and that's what I bring to evaluation. Then we have program logic or theory of change. So what do we mean by program logic, and why do we actually need one? Well, that's where we actually put in a framework, what are our resources, what are our activities that we're going to do across a range of stakeholders or partners or people in an organisation, and then what are those outcomes, so that we've got a bit of a roadmap so we know where we're going. I'm going to talk about a few different frameworks today, just because I like frameworks apparently. So monitoring and measuring success. So this is where we want to know the why, the how, the indicators, and then what are all those different data sources that we actually need. And I'm going to get even more confusing as I keep talking because of the program that I'm actually going to talk to you about. So I'm also going to talk about integrating activities across stakeholders and different levels of program delivery. So we've heard lots of presentations today, and unfortunately I wasn't here yesterday, but I did follow the conversation on Twitter. And I know that we've talked about multiple levels of behaviour change, and they're really important. And sometimes one particular interventional program is actually targeting different levels in those systems. So how do we identify the gold standard for program delivery and sustained funding? You know, that's the question we all want to know, and the standard we stick to as well.
You don't do it for the mirror or for the scales. You do it because it feels good. It feels good changing habits and kicking goals. Start feeling good now with a program personalised to you and have support from a team of health professionals. My Health for Life is a free, healthy lifestyle program funded by the Queensland Government. Find out if it's right for you at myhealthforlife.com.au.
So you can see by that last picture in the slide, there's lots of stakeholders involved in My Health for Life. Now, I know there's some people here from Queensland Health. This is a huge Queensland Health funded program that I had the privilege to work alongside Sharon, Julia and Abby of doing the concept proof for the program. So that's where we actually worked with the consumers. We also worked with health experts as well. There'd been a huge systematic literature review done as well to inform the program. And then now I work on the evaluation team with a group of people from the School of Nursing, the School of Medicine. So there's biostatisticians, so that's really lots of fun when you love numbers. They are fantastic. So just a quick overview I'm going to give you this afternoon. Just a look at the Healthier Queensland Alliance, the program overview, the evaluation approach that we use, the program governance, and how we use continuous improvement as well. So this is what the Healthier Queensland Alliance looks like. And now, I don't think I'm speaking out of school here, but this alliance made Queensland Health very nervous. Typically, alliances don't work very well. But I can happily say this alliance does actually work well, but that's because of all the governance that's in place to make it work well. So you can see there's a range of different government organisations and non-government organisations there as well. And they all have different roles to play in the actual program delivery. For example, the Stroke Foundation does all of the risk assessments, which I'll talk a little bit about in a moment. Then we have the Ethnic Communities Council of Queensland, who work with the culturally and linguistically diverse communities. We have QAIC, so Queensland Aboriginal and Islander Health Council. So there's a range of different stakeholders there, all doing different jobs. So My Health for Life seeks to complete 10,000 Queenslanders in this program, and they also aim to complete 200,000 risk assessments, and the risk assessments are the AusD risk tool, which is actually a tool that looks at risk of type 2 diabetes. The program that we worked on developing is 6 sessions and then a maintenance program as well, which is online. So the 6 sessions are either group-based, where there's 8 to 10 people in a group, or they're conducted via telephone health coach, so just depending. There's also, using social marketing, some principles, segmentation. There's also 5 different languages that the program runs in, and it's also specifically developed with separate resources for the ATSI population as well. So Haruka made me a lovely map that looks a bit like the Foresight obesity map. This is a really complex program with a lot of stakeholders. So when we were looking at PHN, for example, they actually work with the GPs. We also work with the hospital and health service across Queensland, so working with the local hospitals as well, amongst all of the other stakeholders. Lots of councils are involved because we do community engagement and activation. So it's really complex, really, really complex. So moving into our evaluation approach, we use a public health framework as one of our frameworks, which is the RE-AIM framework. So I'll quickly move on because I'm very quickly running out of time. So these are the actual research questions that we use for our evaluation. So looking at, and if you look carefully at all of those, you'll see that there's different levels of evaluation. So we're looking at community, we're looking at individual, and we're looking broader than that as well. So looking at whether community knowledge and attitudes change or not, and then looking at individual level factors as well, and then looking at organisational level factors, so looking at how acceptable the actual program is. So we also collect data from a range of levels as well, and from a range of data sources. So we have the individual level data, which of course most of that's self-report, and we also work with Enhance. So you heard George speak yesterday. They collect all of the consumer data, which is on a much smaller sample of participants who complete, but also non-completers. So we actually go in and ask people what stopped them from completing the program so that we can get a true understanding of what works and what doesn't. Because as I said before, we use a continuous improvement model. So we're always feeding back into the program, making tweaks and changes. So you can see we look at program acceptability. We also measure all of the fidelities as well. So that's how well each particular facilitator delivers the program. So we're making sure that everybody's getting an equitable dose of the program. So what we've actually looked at is the effectiveness, so health behaviour changes, looked at the benefits and barriers. So and I'll talk a little bit in the next slide about that. The dose delivered and received, the fidelity, the recruitment. So we actually look at the pipeline. So when people do the risk assessment, that could be done face-to-face or it can also be done online. And we're currently working on that and changing the service design around that because some places that hasn't worked particularly well. And then also looking at the potential of the program so that this can go into another funding cycle. We're now working at program sustainability at the organisational level as well. So in our first year's report, after the program had been running, there were a few things that we could see were working really well and some things that weren't working so well, and that we've now implemented changes to counteract that. So some of the things were about improving the conversion of eligible participants. So people might do a risk assessment, which is an awful name, and consumers don't actually like that, and getting them to go, if they are eligible, and there's very strict eligibility criteria as well, to actually get them to move into the program. We've upgraded the website as well and changed some of the brochures and other marketing collateral. The telephone health coach, the retention was a little less than the group-based program, but we have started focusing on the pre-post session one, so implementing some keep warm strategies to actually keep people in the program. And then starting to capture some of that satisfaction data as well, and trying to do that without getting any bias from the provider, because normally the facilitator is the access point. So we've now started actually using a text message system to collect that data to reduce the bias. And that's been really interesting getting that feedback as well. So this is a rough tree of all of the things that we actually do. So you can see there's lots of different activities. So we look at a variety of levels. So looking at the environment, so looking at the food environment, the physical activity environment, the health services, which includes gyms and things like that, and what's available for participants, or what are the barriers or facilitators for them to be able to maintain their health behaviour changes. Looking at the net marketing contribution. So actually, and this is a really complex program to be able to do that for, because we have community engagement, we have TV ads like you saw, and a range of other activities as well. So it's coming from all different directions. So it's not simple. And then we've updated the evaluation surveys as well after 12 months, which they've just gone back into field. So then, we had to work out how do we harmonise the data so that we don't lose the data from before. So it's been a long process, but continual improvement, as I said. So key takeaways. How do we connect multiple evaluation activities at the individual and community level from a variety of stakeholders and contractors? So we need a variety of frameworks, not just one framework, because it's not just a one-size-fits-all. And we've really had to tailor some frameworks to meet the requirements of this program. And we've been able to identify key areas for improvement and measure program effectiveness. And our findings can be used to inform future programs and policies. So this program isn't a randomised controlled trial. It's huge, but we operate in a living laboratory. So what we're doing is actually looking at all of the different confounding factors so that we can make informed decisions. In a randomised controlled trial, in a lab, we can change things or control things, but we can't in the real world. So that's why we've developed this huge evaluation framework that allows us to capture some of those things so that we can actually identify why behaviour is changing. Thank you.